On behalf of NHF, welcome to Health Insurance Basics for people with chronic health conditions, also known as Insurance, What You Need to Know in 2021. My name is Bill Roby. I'm a Senior Manager, State Government Relations for NHF. To get the most from this session, please use the chat box to write in questions or comments. The speakers will try to respond to as many as possible at the end of the session or in the chat box as they can throughout the session. Please make sure to fill out the evaluations and give us feedback so we can make an even better 2022 BDC. This presentation will be recorded and will be available to watch online after the conference. Our speakers have no disclosure. Michelle will not be a panelist today, but she will be in the chat answering questions following the presentations. It's my pleasure now to introduce my colleague, Colette Koulianos.
Sorry, my apologies. Are we on the, all right, sorry, I'm looking for the agenda slide, my apologies. Okay, so today we are going to cover several topics that Marla and I will go back and forth to discuss, but we're going to go over the importance of selecting the right insurance plan and knowing when. And then that'll cover topics such as healthcare literacy, health plan types, what open enrollment considerations you should be aware of, and then total cost analysis and how and why that's important for patients with chronic conditions. We're also going to review the Affordable Care Act, which is the ACA, or also known as Obamacare, and what the protections are, what the essential health benefits are, and then what changed as far as OE dates, navigators, assisters, and number of insurers in the market and breakdown, et cetera. And then we're going to talk about the rules that are changing around the use of copay assistance, known as copay accumulators or copay maximizers, and then state and federal anti-accumulator legislation and what we've been doing to help stop these practices. And then a new scheme that's been known as alternative funding, which we'll go into, and what you can do as a consumer and the resources that we have available on the NHF Health Toolkit. So next slide, please. So it's important. Selecting the right health insurance plan is important for anyone, no doubt. But getting the proper coverage is a must for those people with chronic health conditions. Health insurance for chronic conditions is a constant dilemma for the millions of people in our country who suffer from them. However, with the Affordable Care Act, which was passed in 2010, it did prevent insurers from barring coverage or charging higher rates due to pre-existing conditions. But there's still many considerations within the type of plan that you can choose that can impact whether or not you're going to be able to have access to care. So we're going to go over these topics in further detail. Next slide, please. The first issue really is around healthcare literacy. I mean, even people who are in this field, who do this work all the time, Marla, myself, Michelle, we get stumped by terms. They're always changing terminology and use of acronyms that confuse consumers. But just in general, only 9% of Americans understand basic healthcare literacy. That's what is a premium, what's a deductible, copay, coinsurance, and what of those count to my max out of pocket. So even though that's a slight increase, I would still say that even though the numbers say 9%, when I'm in a room and I say how many know, I usually get more than 9% with raised hands. But then when I start asking questions, the hands start going down. So it's really important to know these basic terms before you pick your next plan. So the key terms, your premium, that's what you pay to get health insurance. So if you get a marketplace plan, you are charged a premium. If you have employer sponsored insurance, which means your employer pays a certain percentage of your premium and you pay the rest, what you pay to get your insurance is your monthly fee. And that's what you pay to be qualified to be in a health plan. If you stop paying your premium, you no longer have health insurance, just like a gym membership. You pay every month, you can go to the gym. You stop paying, you're not admitted. Same with your health insurance. But your premium doesn't count towards your max out of pocket. And many people don't understand that and believe I'm paying $12,000 a year on my premium for my family. What do you mean that doesn't count to my max out of pocket? That's the cost of getting health care. What does count to your max out of pocket is the deductible, any co-pays, co-insurance. Those three things count to your max out of pocket. But over 85% of people in our country have a deductible on their health plan. Now, the deductible can be as small as $200, $300. It can go all the way up to $7,000. Any deductible that is $1,400 or higher is considered a high deductible health plan. That's for an individual, or double that for a family. If you have a deductible, you have to pay the entire deductible before the plan will pay the first penny. So I'm going to say that again. You have to pay the entire deductible before the plan will pay the first penny. So if you have a plan that's a high deductible health plan, it's anywhere from $1,400 for an individual up to $7,000, and double that for a family, right? $2,800 or $14,000. So you'd have to pay that entire amount of money before the plan paid the first penny. So that's why it's important to understand that a high deductible health plan may not be in the best interest for a patient with chronic conditions. Next slide. So what are the healthcare coverage options? They are, oh, I'm sorry. Is this Marla? I believe this is you.
Yes, it is. Okay, sorry. Healthcare coverage options. So when we think about healthcare coverage options, thank you, Colette, for such an excellent overview. There are two basic flavors, right? We have some public insurance and private insurance. And what we're going to do is go through each of these in a little bit greater detail right now. So why does this matter? It matters because you want to know who is paying the bill, who is paying for this coverage. And this helps you understand why payers are making some particular decisions. So as Colette mentioned, you have employer-sponsored health insurance, which is generally through your job. And that comes in two flavors. So you have fully insured, fully funded, and self-funded plans. A fully insured plan is a plan where the employer contracts with another organization to assume financial responsibility for all the medical claims and all the administrative costs. A self-funded plan is like something, if I always use the example of Apple, it's a plan in larger companies or an increasing number of not so larger companies where the employer itself collects the premiums from the enrollees and then assumes the responsibility of paying out the claims, okay? These employers can contract with an insurance company for these services for enrollments, claim processing, and provider networks or a third party, or they can be self-administered. Because it's important to remember, like you're thinking, well, didn't you just say Apple? Yeah, so Apple would contract, let's say, with a United or an Aetna in order to do this. Self-insured plans, this is the most important thing, do not necessarily follow state insurance rules. They're regulated under an entirely different set of rules known as ERISA, which is overseen by the US Department of Labor. Okay. Then you have an individual or family marketplace plan. A lot of you guys should be aware of healthcare.gov and the marketplaces, and you can buy individual and family coverage on theirs as well. And then third, you can go through a broker. And then you have public insurance. When I mean public insurance, I mean Medicare, which is a federal program and is largely for 65 and older and a limited income, limited number of conditions that also qualify. Medicaid is a hybrid program. It's part federal, part state. And Medicaid programs are administered by the state with federal oversight. That's important to understand because if you have Medicaid in one state, it's not necessarily going to be the same as Medicaid in another state. The same is true for CHIP, which is the Children's Health Insurance Program. Some states operate it in parallel with their Medicaid program, some states don't. And finally, you have TRICARE or VA, which is a federal for active and veterans soldiers. Next slide, please. And Colette mentioned acronyms. Acronyms are my second most favorite thing. Dogs are my first. Health plan types come in a variety of flavors. So I always use flavors because I like ice cream. So health plan types are kind of a bit of a word salad, if you will. So these acronyms are not only confusing, but they also are important Okay, so it's important when you say like, oh, what kind of plan do you have? Oh, I have a PPO. Well, what does that mean? A PPO is something called the preferred provider organization. Okay, meaning that they have a preference in terms of which provider you would see. A POS plan is a point of service, and HMO is a health maintenance organization, exclusive provider. The only and high deductible health plan or with an HSA available. But the one I want to focus on right now is a short-term limited duration plan. These are these sort of, they were expanded during the previous administration and then scaled back. They were intended to be short and limited duration, and they were kind of junk plans, if you will. And they were not fully comprehensive. And the Biden administration is also scaling those back to return them to what they were before, which was a stopgap. But all of this is to say that no matter what coverage you have, it's insufficient if you say, oh, I have Aetna. Okay, Aetna probably offers a variety of all of these, right? So you have to say, I have an Aetna PPO or I have an Aetna HMO. So it's important to understand what type of plan you have. Next slide, please. Okay, this is back to Colette, I believe.
Yep. So on Marla's previous slide, she talked about the word salad, if you will, the types of plans. It's important to know those plan types, of course, in general. But what's really important, as I said, a high deductible health plan, remember, is $1,400 is the minimum deductible, that's for an individual, $2,800 for a family. The max deductible on that, an individual, $7,000 for and $14,000 for a family. So if it's open enrollment type and you're looking at plan offerings, if you have chronic conditions, one or more in your family, and you have to pay the entire deductible before the plan picks up, it's likely, especially in our community, that you've counted on copay assistance from a manufacturer in the past, and you may still count on that, and that has been applied to your out-of-pocket. We'll get into it momentarily, what's changing with that, but because of those changes, those may not be the best plans to pick, because if that burden came back to you, would you be able to pay up to $7,000 for one person in your family or $14,000 before the plan paid the first penny? Because if you couldn't, then of course you want to really be careful on selecting that plan. And the short-term limited duration plans, fortunately, the current administration is scaling those back, but those are really catastrophic coverage only. They don't cover medications largely. They don't cover pre-existing conditions. So you would really never want to choose one of those plans, even though they may be the lowest premium offering. So on high deductible health plans, I said over 80%, actually the latest data says about 85% of commercial plans have a deductible. Now, as I said, it could be a low deductible. It's not necessarily a high deductible health plan. High deductible health plans, by definition, I've already said multiple times, 51% of the US workforce is enrolled in a high deductible health plan this year. That's 51%. Now, some states have even higher numbers. There's a map where I often look at and see certain states, you know, there's some states that sit in the 65% range. That means 65% of all commercial plans in that state are high deductible health plans. In 2020, a study was conducted that, sorry, I'm trying to switch my slide so I can read what was on the screen. A study was conducted by eHealth, and it was reported that the average annual deductible for an individual for individual coverage is $4,364 and $8,439 for a family. That's average deductibles. The max deductible is $7,000 and $14,000, as I said, and you have to pay the whole thing before the plan pays. So those are the key things you have to remember. I'm hammering them because when it comes time to select, you must remember that that'll be your responsibility, especially if the plan implements what's known as a copay accumulator or maximizer. So we'll go on to the next slide. High deductible health plans, are they right for you? Well, they're created for consumers to have a health insurance option that'll have a lower premium. The lower the premium, the higher the out-of-pocket. The higher the premium, like a gold or a platinum PPO plan, is going to have a high premium, so high cost to buy that insurance, but a much lower out of pocket. So that's where you have to do this kind of total cost benefit analysis before you make a decision. These plans can be linked to health savings accounts where you can put money in pre-tax. And unlike a Section 125 or a cafeteria plan, or that most, an HSA, HSAs do not operate the same, because on a Section 125 plan, like we have at NHF, we can put the money in, but at the end of the year, if we don't use it, we lose it, even though it's pre-tax. The money has to be used within the year. Now, they usually have a grace period. Ours goes to the end of March of the next year. But with an HSA, you don't lose it. You can continue to build money, save it. And when you retire, you can actually pull that money out. You never paid tax. It was pre-tax. You can pull that money out after retirement, use it for whatever you want, and never have paid tax on it. If you pass away, you can will it to your children or your loved ones, and they can pull it out and not pay tax on it, use it for whatever they want. So there are benefits. But if you're a chronic disease family, the question you have to ask is, will I ever be able to save money in that? Because if my deductible is all the way up to $7,000 for an individual, the max I can save this year in 2021 is $3,650. I could never get in there enough to pay my deductible. So again, the question becomes, is this the right option for a chronic disease family? I would suggest that the more plans that are implementing these copay accumulators, the more it concerns me that anybody choose this type of plan if money is an option or a consideration. And here's the limits I just went over. So high deductible health plans, what we're talking about, it does have a max deductible and out of pocket of $7,000, but look to that arrow over to the right, it's that $3,600 is the most you can put in. And if you're a family, your deductible could be all the way up to $14,000, but the most you can put in your HSA is $7,200. And you can't use the money in your HSA till it's saved. So in January, when your insurance resets, let's assume that's the beginning of everyone's plan year to make this easy. January 1, the insurance year resets, and you're going to start putting money in your HSA. Your first paycheck isn't until January 15th. I'm just making up a date. But you have to get your medicine, and you go to the pharmacy January 2nd, and you want to pay your deductible up to $7,000. Let's just say it's only $3,600. You want to pay your deductible, but you can't access that HSA because January 2nd, there's been no money put in it. You haven't even put your first installment in. You haven't gotten your paycheck. You can't use it until you've saved it. So again, another reason why these don't really work well for chronic disease patients who are on high cost medications like our patient communities are. And next slide, please. So an important thing to keep in mind, the higher the premium, it's going to be a more robust plan, and it's going to have far less out-of-pocket costs. The lower the premium, the much higher the out-of-pocket costs are going to be. There's a direct correlation between the two. So you have to compare your net annual costs. What's my premium going to cost? Remember, if you're an employer-sponsored plan, which like 80% of all commercial plans are employer-sponsored, meaning the employer pays some portion, then you have to look at how much do you pay. As you take your monthly premiums, this is what I mean about doing a total cost analysis. This is how much I pay for my premiums. So at the end of the year, I'm out of pocket this much, but my total out of pocket for my any deductible copay and co-insurance is much lower on these more robust plans. So the max I'd be exposed here is this, add it up, okay. Now you look at if I'm in a high deductible health plan, my premiums are lower, so I'm only obligated for this amount, but my out of pocket's way higher, which I will hit because I have a chronic condition with high cost treatment. So then you look at and you go, this isn't my best option, is what you might find. Now, it depends on the type of plan, and various companies pay more, some pay less. Some will pay more for you as an individual, but if you want to put your family on your plan, you have to pay a higher percentage for your family. So again, you have to do an analysis to make sure it's right for you. And so we'll go to the next slide, and that is Marla.
Okay. So while the ACA is not perfect by any stretch in the imagination, it did a lot of fantastic things for the community, right? It offered a number of consumer protections that not only protect you in terms of getting insurance, but also control the cost of your insurance, right? What it did was it expanded access to well over 30 million people who were previously uninsured. This does not include those that were underinsured, meaning that they just had like really not fully comprehensive insurance, but rather just okay insurance, if you will. It eliminated the ability for insurers to exclude you because you had a pre-existing condition and charge you more. And it eliminated the lifetime benefit limit on EHBs, right? So before, that was one of the huge things that this community did, was advocate for eliminating the lifetime limit, which was the benefit limit either in number or dollar value. And it did extend the ability for young adults to remain on their parents' plan, good or bad, it depends. And it allows them to stay on your plan until age 26. It also established the health insurance exchanges and/or marketplaces. Some marketplaces are state-based, like in New York, it's a state-based marketplace. 20 of the 50 states have state-based marketplaces, and 30 are operated by the federal government or by the federal and state government. And it also expanded Medicaid coverage. States had the option for expanding Medicaid coverage to previously unserved populations, and as well as expanding the income eligibility of said Medicaid coverage. Not all states did expand Medicaid, so you need to look to your state and see if in fact that your state did expand Medicaid. Next slide, please. Okay, so on the previous slide, you saw EHBs. What are EHBs? EHBs are essential health benefits. That's what the ACA did. It established 10 categories or classes of services that all plans, irrespective of type, must cover. And you can see here on the left-hand side of the slide what some of those services were, right? Ambulatory, emergency, hospital, but what was most important is it included, sorry, I live in New York City, so there's always ambulances. But it included prescription drugs, rehabilitation services, laboratory services. One of the interesting things was, if you've been following some of the vaccine discussion, was these wellness or preventative services, which wellness programs are different than preventative services, and pediatric services. And within those categories, that's where your dollar limit is, meaning it has to apply to one of these 10 categories or classes. But what the ACA did is establish the floor, meaning you can't go below this point. You can go above this point, and a lot of states have, in fact, gone above this point. But they didn't include specifics, meaning they didn't include the duration, meaning how many, or the duration, meaning how long they can have these benefits for, the amount, meaning do I only have 10 physical therapy covered services, or do I have 20? And it also didn't include specifics about the scope of services. This is what, in part, why the ACA is a little bit imperfect with respect to the essential health benefits. And I'm just going to pause here for a second. Colette, wanted to mention something.
Yeah, thank you, Marla. I think, it's really important to understand the ACA, Affordable Care Act, is the same thing as Obamacare. People think it's different. You just heard Marla talk about what the protections were from the ACA, had to cover pre-existing conditions. That isn't how it used to be. If you would have enrolled in an insurance plan, a new plan, and you had a pre-existing condition, whether it was asthma, whether it was something more serious like hemophilia or worse, they could say, I'm either going to charge you a way lot more for that because you have this condition, or they could say, we'll cover everything else, but we're not going to cover your asthma. That was pre-existing. Or they had lifetime caps. So those are the protections patients had. And then, of course, the essential health benefits. Now, why did it help our community? Because they had to cover prescription drugs. That wasn't always the case. So I point that out because during the elections, there have been so much rhetoric on both sides. And I'm completely being agnostic as I speak. I'm going to talk about the facts. This isn't a political advertisement. But if for our community, if having these benefits is the most important to you and your family because you have a chronic condition, because without them, what would you do? Then when you vote, you have to understand that these protections, where they lie and who is trying to protect them. If there's other things that are more important to you, then you have to decide who's going to protect that. But I will tell you that anything else that other than these protections must stay. They had bipartisan support before 2010 for the main things like pre-existing conditions and lifetime caps. But we heard a lot of folks say, well, we don't want to take those away. We just want to give states the choice to pick which essential health benefits. We don't want to have to pay for maternity. Why should, I'm a guy, why should I have to pay for maternity coverage on my plan? Well, it takes a guy for a girl to get pregnant, that's the obvious, but why do I pay taxes for the parks or the schools? I don't have kids in school, and mine are raised. Why do I pay for streets in Illinois for my property tax? I don't even live there anymore, but I still have my home there, because it's what we do for the betterment of the area we live and for all involved. So I just want to make sure that you understand where those protections lie and that we must keep those protections for the millions of people who have chronic conditions. Those are critically important. So I'm sorry, go ahead, Marla.
Oh, okay, sorry. Next slide, please. Now this comes up a lot, right? So often we'll get calls like, well, I thought the ACA had to do this, right? And it turns out, do all plans have to be ACA compliant? Absolutely not, right? There are a number of exceptions, right? There's grandfathered and grandmothered plans, which are a bit of a new category. Earlier, I mentioned when I was talking about the employer-sponsored health insurance, self-funded plans. Remember, those plans are governed by ERISA, which is a very archaic law. There's numerous challenges to whether or not what should ERISA be in charge of. And there's also partially funded plans, which are can be the exception rather than the rule. And this is sort of an important nuance to it a bit, is that you can exclude treatment coverage for certain conditions, provided it applies to all the beneficiaries. So you can't say, I just don't want to cover you, Colette, but I want to cover everybody like you, Colette. And provided it does that, then in fact, it is legal. You can include types of medications, right? Specialty drugs or orphan drugs, and that is in fact legal, provided that you exclude all specialty drugs or all orphan drugs, right? And I think that that is a super important distinction to be made, because a lot of people don't appreciate that, oh, I thought the ACA protected this, and you're like, it did kind of, but not right now and not right here. Next slide, please. Okay, so let's talk a little bit about open enrollment, okay? Above all, you have to pay attention to the dates and deadlines. I cannot emphasize this enough, because even though you know you should do it by November 1st, these are hard deadlines, okay? These are absolutely hard deadlines. So if you're saying I didn't do it by November 1st, there is no opportunity on November 2nd for you to enroll, provided there's a number of limited exceptions, and we'll go through those in a second. They vary by type. When I say they vary by type, if you have a marketplace coverage, well, it has one open enrollment deadline. And if you have employer-sponsored insurance, they have their own based on not only their calendar, but when you started in some cases. So those two, so if your spouse has employer-sponsored health insurance and you have marketplace health insurance, they may not necessarily have the exact open enrollment time period. The marketplace's open enrollment for 2022 starts on November 1st, and it goes through December 15th. Those are hard deadlines, okay? You cannot, if you go to December 16th, it may not work because, as you recall, 20 of the states that operate their own marketplaces, they can kind of do whatever they want to cover their populations. But for the 30 federal marketplaces, these are in fact the dates. These are also the original dates when the marketplaces first opened, and they had a longer enrollment period. Then the Trump administration shortened that enrollment period by a lot. And now it's been reinstated to be a longer open enrollment period. And there's been a current proposal to extend it through January 15th. If you follow us on social or get our newsletters or read any of our articles, we always tell you when these sorts of dates change. We went through a lot when the American Rescue Plan was, when the American Rescue Plan went into effect, that, you know, that these dates were changing, right? That you had a special open enrollment period as it related to COVID. But it's important to understand that if that changes, don't take my word, because this is all TBD, right? This is to be determined. So for now, it is November 1st through December 15th. Most state-based marketplaces, like New York State, is open all year round now in response to COVID. But you have to check your specific state's exchange. So you can't say, well, in New York, they're open, but I live in Ohio. It's not going to be the same. And you have to really appreciate that. And California, Colorado, and DC, for example, have permanently extended their open enrollment period, meaning it's not tied to COVID at all. Also important with respect to marketplaces is the American Rescue Plan. It'll pass in a second. I do live in an apartment inside. Have enhanced subsidies. These subsidies will still be in effect in 2022. This is an important distinction, right? Because a lot of times before the American Rescue Plan, there was what was known as the subsidies cliff, meaning if you made over 400% of the federal poverty level by $1, you had to pay a whole lot more, and which, you know, disincentivized enrollment for people who made above that level. But this eliminated that, and for now, it is only in effect until 2022. And currently, a vast majority, an overwhelmingly high majority of citizens, US citizens, are available for free or reduced cost coverage. And you're sitting here saying, that can't be true. Yes, it is in fact true, because you cannot pay no greater than 8.5% of your income on premiums, period. Right? So if you make, you know, $500,000, you cannot pay more than 8.5% of that on premiums. And your premiums are adjusted accordingly. So they did make a huge dent with respect to how they adjusted the cost, out-of-pocket cost on premiums, okay? But what's important to remember is that any open enrollment policy, once you sign that policy, it's like a signed contract. It is no different. You have signed a contract and enrolled in a plan. It is very, very, very hard to change any of that without a qualifying life event, okay? What are qualifying life events? Birth, death, that kind of thing, marriage, divorce. That is the only time you can change coverage until the next open enrollment period, provided we're not in a pandemic. Excuse me. Next slide, please. Okay, everyone needs help. I saw briefly when I clicked on the chat before I minimized it. Everyone needs help, but you have to really ask for help from a non-biased professional. When I say a non-biased professional, everyone's going, well, my brokers are biased, okay? Because brokers are trying to sell you a product. In the marketplaces, there exists something called navigators and assisters. Navigators should be more widely available starting this open enrollment period on November 1st. And I know that because we did the review for some of the Navigator grants, and they were just awarded. The Biden administration increased that to $80 million. So there are 60 new navigators in the 36 states that use healthcare.gov that are eligible, that have been awarded funding to help people. Not only do they help people with enrollment, but they also help people understand and figure out their benefits. And that's an important distinction, because during the Trump administration, they drastically scaled back what they could do and what funding was available. First, they scaled back what the funding was, which then by definition scaled back what they could and couldn't do. But now they were having an expansion to the duties that navigators were intended to and are trained to fund, are trained to understand, which would allow post-enrollment assistance. That would be fabulous if post-enrollment assistance was available, because a lot of consumers really, really, really need post-enrollment assistance. Okay, but remember, aside from the policy being a contract and that kind of thing, as Colette mentioned, you have total cost considerations and affordability. And what are your personal preferences? And remember, my personal preferences are different than Colette's personal preferences. So if you're taking advice from a cousin or whatever, your preferences may be different and likely are different. What you can afford is going to be different than what I can afford and what my cousin can afford, right? So all of these considerations are very, very personal decisions, okay? Next slide. Okay. There's been a lot of talk since the marketplace has opened about, well, we only have one insurer, okay? In fact, if you look just quickly at this graph on the upper left-hand side, there's been, while there was a drop off in the number of insurers that participated in the marketplaces, there's been a steady increase in the number of insurers that participate in the marketplaces. And in fact, with more insurers in the marketplace, you means you have a greater number of choices in the plan options, okay? So for example, on the right-hand side, you can see some of the new insurers that are entering the markets in an assortment of states. Some of these plans are regional. Some of them are obviously not, right? Aetna, or personally, I don't know Friday health plans. But these are all new to that state's market. Within that is competition. So there's multiple insurers that are going to be looking to have more consumers into their market. And if you look at the lower left-hand corner, you'll see over time, there's been a gradual increase. The marketplaces are extremely stable. When they first opened, they were unstable and people were concerned that they were going to fail. But they are entirely stable. Insurers are profiting, and insurers are actually expanding, not only participating in, but expanding in the number of plans that they are offering within a given marketplace. Sorry, there's a very odd sound coming. So while there is a wide variation in what's available in Idaho and New York, and the rates that are available, next slide, please. Oh, sorry, previous slide, sorry. Is that these rates, the rates are going to change, right? And the rates are not going to change that drastically based on pre-rate filings that have been released. For example, in California, their rate is only going to increase 1.8% this year, okay? That's important because you're like, well, the marketplace's plans are unaffordable. They may have been unaffordable previously, but remember, because of the rescue plan, they cannot charge more than 8.5% of your income on premiums. So while they may not have been affordable before, they may in fact be affordable now. Very, very, very few states are increasing the cost beyond the cost of inflation, meaning most have a nominal increase and in some cases a decrease in their premiums. And that's an important distinction. So these single rate increases, you know, like in California where it's under 2%, may not necessarily apply to Idaho. I have no idea why I'm picking on Idaho. But it's important to understand that when you look at a marketplace plan, if you had a insurer that was in before and now is out and now is back in, you have to look. And some of these smaller regional plans may be your best option within that specific market. And now I'm going to toss it back to Colette. Colette, you're muted. Colette, You're muted.
Some might say that I'm better that way, like probably you, Marla, but I'm now unmuted. I did want to say that Marla mentioned the grants for Navigator programs that have just recently been issued. And I did want to point out that NHF was one of the grant reviewers for the federal government to give out Navigator grants. And Marla was one of the reviewers. So we're proud of that, that she was asked and that she helped participate in that, and that NHF was able to do so.
And I will, can I just interject again? Because,
Yep.
Right, sorry. And what I will say about that is these are highly trained people. Well, they may not know bleeding disorder specifics. What they do know, they know a lot of. I sat through the training, I reviewed the applications, and I also took the Navigator, parts of the Navigator training myself. And they do know the basics. So you go to them for the basics, and you come to us or your HTC or your CHAP for some of the bleeding disorder specifics. Sorry.
Yep. No, I think that's so important, Marla. Thank you. And I do think, though, I want to preface, because we do tell our patient community, go to your chapter, go to your HTC and get advice. Go, a lot of people talk to their pharmacy. While they can be great resources, it's important to make sure that the only interest isn't that, let's say, the pharmacy can fill your factor. Because we've had multiple cases where patients have actually chosen a plan because somebody helped direct them so that they could get in that pharmacy. But then they turn around and that particular plan would not allow them to use premium assistance, so the families lost the plan. So you have to make sure that you're looking at everything that's important for you and your family. And that's really the whole kind of emphasis for this session. So I talked about high deductible health plans, and I talked about the fact that you have to pay the whole deductible up front. And I talked about if money's an issue, that might not be something good. Even if you currently are able to use a manufacturer copay assistance to help you with those deductibles, because we have data that now ranges somewhere between 60 and 80% of all commercial plans have implemented copay accumulator adjustment programs. And that means that you can use the manufacturer coupon, but it no longer counts to your deductible or out of pocket. So, as you know, manufacturer coupons have a max annual limit. If you have a plan that has a $5,000 deductible and your manufacturer copay card is worth $10,000, then you can use that card for 2 months. I call in January, I get my medicine, they take $5,000 off the card. It looks like I met my deductible, the plan pays the rest. Then I go February, and because the plan is no longer counting that money, they reset my accumulator, which means the amount I paid out of pocket. They reset it to show what I paid, which was nothing, and it shows I still owe $5,000. So they take the last $5,000 off the manufacturer card, and now that card's gone. Remember, it only had an annual limit of $10,000. So then in March, when I go to fill my meds, they say, how do you want to pay your deductible? And that's where our patient community is like, wait, what? No, I paid that in January. No, you didn't pay it, the manufacturer card did. So if your plan were to implement one of those, you have to make sure, could I still afford my deductible? Because if you can't, then you may want to stay away from a high deductible health plan if you have an option. But some employers only offer high deductible health plans. So I think it's important to understand what they are and to be aware, if your plan has implemented them, what other options are out there. Now, most plans will accept assistance from a third-party nonprofit that does needs-based testing. So Pan Foundation, PSI has premium assistance. They don't have copay assistance, but the Assistance Fund is another one that's out there. Patient Advocate Foundation is another one. Unfortunately, when Marla and I check frequently of who has funding available, often it's only Pan Foundation that has copay assistance money available, but you can use that, and most insurance plans to date have allowed that to count, although we have seen some plans that are even excluding that from the language. Now, I mentioned another scheme called alternative funding, and I won't get too deep into this. One, because we're going to have limited time, but two, because it's a new scheme is what I'm going to call it. There's a bunch of companies that have started targeting self-funded health plans. So these are employers who are, as you heard Marla say when she was talking about the different types of health plans. So you have all the people who have private insurance. That means you either have employer sponsored, employer pays part of the premium, or you have marketplace plan or broker plan. If you have employer sponsored, some of those are self-funded, meaning the employer takes the risk, some are fully funded. Because self-funded plans are governed by ERISA, you heard Marla say, they're not governed by the Affordable Care Act essential health benefits. They don't have to follow all those. So they're targeting those plans and they're saying basically to those employers, what keeps you up at night? And of course, the answer is the rising cost of specialty drugs, the rising, the pipeline of all these new drugs coming out, the advent of gene therapy on the horizon. How in the world will we ever get through this? And so these companies have just in the last year started sprouting up, and they go to the employers that are self-funded, and they're really focusing on those companies that are in the service industry or manufacturing. Now, it doesn't mean they won't go outside that, because they have. We've seen it in universities, on multiple universities actually, but they started focusing on those. And they're saying to those employers, here's how we can help you. They are going to help you reduce your specialty drug spend by up to 100%. How? You are no longer going to allow patients to have that benefit covered on your plan. In other words, you're going to remove those high cost specialty drugs off your plan, and you're going to show they're not covered anymore. But don't worry, we're going to help patients through this concierge service, this white glove service. And what we're going to do is we're going to find alternate funding for these people to be able to still get their meds the same way they always did. What that really means is they're going to take the patient over to the manufacturer charitable assistance program, and they're going to try to apply on behalf of the member to get them free product from the manufacturer. Those programs from manufacturers were never intended to give away drug free to everybody. You have insurance, you pay your premiums so that you have coverage for these things. Manufacturers will not be able to sustain that. There's so many, this is fraught with so many risks. One is it's not the manufacturer's job to make sure that your medications are delivered every month on time. They're not in the business of being a pharmacy. When manufacturers do give free product, which is a wonderful service manufacturers all offer, they don't send supplies. So you don't have your infusion supplies that come with it. That can cost, I mean, I ran, before I came to NHF, I ran a hemophilia treatment center, which included a specialty pharmacy. And some patients who had ports, our monthly supplies, which we never billed for, could be up to $650 a month our cost. You can't just walk in a store and buy a port sterilization kit, infusion needles, butterfly needles, saline. That stuff all requires prescriptions. So how are patients going to access this? And so, and that, you know, they go through a very long process of approval. The programs are fraught with issues. These companies are popping up and doing this because they make 30%, in some cases more, of whatever they save the company. So it's a big moneymaker for them. So these are things that we've been from the beginning of finding out what the copay accumulators and maximizers are. Now we've taken this on the national level. We've gotten other disease groups engaged. We are going to legislators. On the copay accumulator and maximizer, we're working with states. We have now 11 states and Puerto Rico that have passed anti-accumulator bills. So we are continuing to fight on behalf of our community. And so Marla, I'm going to turn it over to you for the end.
Okay, and I know Michelle wants to ask a question. We have exactly 1 minute left, I believe, or 2 minutes left. But what you can do, just prepare. Don't wait till the last minute. And for the please open your mail. Please open your mail, and do not call the day before and go, well, I had to make a decision by tomorrow, right? These decision processes take time. So do pay attention, and everything changes. So you have to really understand what you're looking at and prepare accordingly. Michelle? I thought Michelle was going to answer.
I actually don't have a question, but I was trying to answer someone else's question. How do you find out if their plan is self-funded? Look at your health insurance card. If it's a fully insured plan, you'll probably see in the bottom right-hand corner, either on the front or the back, something that says underwritten by, and it'll say the name of the insurer. If it's a self-insured plan, it may say administered by, say, for example, United Healthcare. And Colette, you're muted, but that
Muted.
is one way to be able to tell if it is a self-insured plan.
Mhm. They don't all say that, but they'll say administration services only, or, you know, don't have any financial risk, but they don't all say that. So if you can't get the answer there, talk to your HR department and ask if you're fully funded or self-funded is another way you can find out, or call your insurance company.
Next slide, please. So you want to just go to the
Actually,
last slide?
Yep. So
So just to put our, just to put our email addresses, and we are available anytime. There we go. And feel free and reach out. Federal poverty, any of us, and we can help you as soon as we can. And we do this all the time. And thank you for your time. And we enjoyed this session. And I'm sorry we couldn't go longer. Colette?
Thank you, everybody. I appreciate your attention. And like Marla said, we are available and happy to answer any questions. Any of the questions we might have missed in the chat, we will respond to you after this.